healthcare in between. Physics, art, and math got us down this path. Historical tales come alive, where science and stories dive. Blended facts with heart, knowledge from the start. Meet rich blues we sing, to the future memory. Health and science in the mix, Meet got the fix. Complex subjects make
right
clear
now
every episode
in ways that we actually acquire
leads the way,
and ways that make me more efficient.
in the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is truly an honor and a privilege.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges.
Hey, welcome to the MedBix Webcast. This is Ramana Raju. Welcome. I want to tell you, I went recently to Chicago. I attended American College of Cardiology, and I attended one of the best conferences of American Association of Cardiologists of Indian origin. All Indian doctors get together, cardiologists get together. I've been attending that conference for a long time. I'm not a doctor, but I attended this. I'm a supporter of Dr. Nanda and all those people there. I know Dr. Nanda for the last 30, 40 years. So it is a really privilege to meet at that time Dr. Nathan Wong. Just before that, I wanted to tell you a little bit about that. I have two children. They're mixed race. They're my ex-wife is African American. I'm Indian, as you know. So we have a mixed race. When I was interviewing American College of Cardiology innovation officer Amy Butt, she's a cardiologist. She was on my podcast. I told her I got my children. What the risk factor? She just covered her face with both hands. They're like a double strike. For the kids. So there is no other better person to get that kind of information about the risk factors, cardiovascular risk factors, because she was concerned about me as an Indian is a very high risk factor, and then African American is a much more higher. So it is a kind of a double whammy for us. So I attended Dr. Nathan Wong's thrilling lecture. It's really so informative, so educational. Dr. Wong, let me introduce you. He's a prolific researcher. He's an epidemiologist from UC Irvine, California, UC Irvine. And then he has 400 publications. He wrote several chapters in the books, and he's the director of the cardiac prevention program. And then he's a frequent visit to India. He did a lot of, India is the biggest problem. They have 1.4 billion people. There's a catastrophe in making. A time bomb is ticking for India because they're all now, they're not young anymore. They're getting older. In 20 years from now, it's going to be a huge problem. There's a huge number of older people where the catastrophic problem is going to be there. Let us see what Dr. Nathan Wong says. Let me bring him to the table. Let me bring him to the stage. Dr. Wong, welcome to the MedBix Webcast, sir. It is a privilege to have you.
Well, thank you very much. Privileged to be with your group here, and looking forward to an entertaining evening. Should I share my slides here?
Yeah, just tell us a little bit about you before you go. Anything that you wanted to say? How did you say about India a little bit, and your trips to India a little bit? Introduce just your background a little bit, if you don't mind.
Okay. Well, so I'm a cardiovascular epidemiologist, as you said. Did my Ph.D. work at Yale University, and was born in California and been on the University of California Irvine cardiology faculty since 1988, specializing in preventive cardiology, been involved in numerous studies and clinical trials. And recently, over the last 7 or 8 years, I've become very involved as an international advisor for the Lipid Association of India. So I've had the great pleasure of meeting so many kind colleagues throughout India, and been to many of India's finest cities and sites, and have really had the opportunity to help with several of the Lipid Association of India consensus documents. So I'll be talking about some of that as it relates to prevention of cardiovascular disease and lipid management, and really focusing on my topic of lipoprotein little a, which is really a significant problem in the South Asian population, and something that really all people in India and throughout South Asia need to know about. So I think with that,
yeah, that's fine. Very good. Thank you so much.
I think, as I was saying, South Asian people originally mainly from India, Pakistan, Nepal, Bhutan, and Bangladesh, some from Sri Lanka, where I had the pleasure of visiting last year, as well as the Maldives. And about 20% of the world's population is South Asian, and about 5 million actually live in the United States, probably even more than that now, based on those statistics being several years old. So we know that about, what's interesting is about 60% of the world's heart disease burden originates from India, even though they're only about 1/5 of the world's population. Heart disease strikes at an earlier age among Indians, and higher mortality rates. And about half of all heart attacks in Indian men occur under the age of 50, and about 25% under the age of 40.
Dr. Wong, that
Yes.
in the Hyderabad, I am from Hyderabad, you're saying that the diabetic capital of the world. That's what you're saying.
Yeah.
Tell us a little bit about Hyderabad here.
Yeah, it's and certainly diabetes and metabolic syndrome are very significant problems in the South Asian population, I think, as most of you know. And here we're really looking at the fact that there's a lot of people in South Asia that suffer from premature events. So their average age of severe coronary disease is quite a bit younger, 53 versus almost 59 years of age. And then here, let me just...
Yeah,
Okay,
we see it.
maybe that's a little better there, right? Okay.
Yeah.
The slides are larger. Okay.
Yeah.
And so here one can see how throughout the United States, South Asian individuals have higher mortality rates than other ethnic groups. Okay. And this is, you see this across pretty much all ages, right? The red line is South Asians, and then the other ethnic groups fall below that. So, there's many determinants of cardiovascular disease that really hold in all populations, but in this article from my colleague, Dr. Kalra, who is from Louisville, Kentucky, he pointed out in this statement he wrote a few years ago that some of the key factors that are important to highlight, right? So metabolic syndrome, we're going to talk a lot about lipoprotein little a, certainly genetics and family history, atherogenic dyslipidemia, psychosocial factors, and then many of our classical risk factors are also very important, right? In particular, diabetes and hypertension and overweight issues and poor diet. We also have, of course, visceral adiposity is particularly common in South Asian individuals, and that, of course, relates to greater levels of inflammation, non-alcoholic fatty liver disease, and insulin resistance. The InterHeart study was instrumental in teaching us about different risk factors among South Asian individuals and other ethnic groups among people who first suffered an acute MI. And so in this study, right, 9 factors identified about 90% of the risk. And you can see here that
Dr. Wong, is it before Framingham study? This is a before InterHeart study. I never heard.
No. Actually, Framingham, interesting you raise that, because I did my Ph.D. work with the Framingham Heart Study, and that started in 1948. Remember, so that's the longest running major heart disease study, and Framingham was a prospective study, right? So they started mainly with people free of coronary heart disease, but InterHeart had a different design. It was a case control. They took people who had suffered a myocardial infarction and compared them to people who did not. But what this slide here from InterHeart illustrates is how common and more prevalent certain risk factors, particularly elevated ApoB to ApoA ratio, diabetes, physical inactivity, poor diet, these factors also were more common among South Asians. I mean, they did tend to have less hypertension. Now, this is a fairly old study, so some of this has changed, I'm sure, but it's just important to understand some of the risk factor differences. A more recent study done in the U.S. compared South Asian people in the U.S., and you can see their higher prevalence of coronary disease, 11%, much higher than the other groups. Even African American individuals was at around 8%. Diabetes was 29% among South Asians in the U.S.
Oh my.
Even double that of diabetes and Hispanics.
So,
usually thought to have the
so it is
highest.
higher risk than African Americans, South Asians?
Yeah, and even Native Americans. Native Americans are thought to have the highest prevalences of diabetes, but the South Asian people, and we've done a lot of work with diabetes as well. That's a whole nother talk about multiple risk factor control, but people have to understand, and your South Asian patients need to understand that diabetes is not just about blood sugar. It's a cardiovascular issue. And if we can get A1C, blood pressure, and LDL cholesterol well controlled, you can reduce risk of adverse cardiovascular outcomes by about 60%. That's what our data shows among, not specifically in South Asians, but among other ethnic groups. You can also see, but what's interesting is that high LDL cholesterol is not necessarily more common in South Asians, right? So what's happening is that they're suffering early coronary disease despite similar, or in some cases even lower, LDL cholesterol levels in other groups. But the prevalence of low HDL, you can see, is quite high, and high triglycerides, look at that, 70%, more than double that of other groups, right? So this atherogenic dyslipidemia that is common in particularly in people with diabetes and metabolic syndrome, low HDL and or high triglycerides is much more common in South Asians, right? And remember that your atherogenic dyslipidemia, even if the LDL is not seriously elevated, predisposes you to the more atherogenic small dense LDL cholesterol. So one of the things that we have to think about is how do we best assess cardiovascular risk in South Asians? And, you know, and as most people know in the United States, and, you know, we have the pooled cohort risk score, the ASCVD risk calculator that's shown on the left and has certain risk factors, but does not include South Asian ancestry to choose from, and that's the same problem with other risk scores, you know, like the European risk scores. But the Q risk is about the only one that actually does include South Asian ancestry. This is developed from the UK, so it of course, you know, the extent to which it is applicable in South Asians and other parts of the world, we're not certain, but at least it does include South Asian ancestry. So you can calculate your 10-year risk there. There have been suggestions like from this.
Excuse me, sir. Is that the test that you do? Is it what kind of test you do that, or the score you're measuring? Is there any? You have to do some kind of any scoring, or just a plain racial composition and triglycerides or blood test, or what?
Yeah, nothing unusual. I mean, yeah, this typical blood test. Yeah, you don't need any specialized lipid testing or coronary calcium scores. I mean, it does ask you though if you have rheumatoid arthritis or chronic kidney disease. So you need to know a few more things than you do from the other scores, but it is meant to be implemented in an office-based practice, so does not need specialized testing. I mean, but we're going to get later onto how we can incorporate Lp(a) into a risk score. That's a very interesting topic. So here, what we have is people. These are some recommended risk factor levels for South Asians from the statement that Dr. Kara wrote, and you can see here that you know. One of the things we have to understand is that there's lower cut points for abdominal obesity in Asian individuals. So this, like in East Asians, South Asians, we want to see that waist circumference below 80 centimeters for women and below 90 centimeters for men. That's very important because remember, it's the visceral adiposity that drives a lot of these risk factors. And BMI below 23. And then we're going to talk more about lipids and what targets we should have, particularly for LDL cholesterol. Triglycerides, like in other populations, we want that below 150. And A1C, ideally below 6%. And Lp(a), we're also going to talk more about that. But think about, you know, because South Asian individuals do have higher risks. So we need to really think about all the possible therapies we can to lower their risk. And you know, as we know, there's a lot of attention now about the cardioprotective effects of GLP-1 receptor agonists or SGLT2 inhibitors. And we want the cardiologists to embrace these newer therapies, right? And not think of them just as diabetes therapies. Low-dose colchicine also has benefits. We can talk about that if you want in the discussion. Certainly, this is the only slide I have on tobacco, but tobacco is a problem among the South Asian population. So obviously we need to do what we can to get people to quit smoking, guide them towards smoking cessation. Group programs have good benefits. What about diet, right? So we want to stay away from the unhealthy foods. I just love the food in India because it tastes so good, but
That is a very popular dish, popular sweet.
yeah, it's not always the best thing, particularly that sweet on the top left there. That's my favorite.
Yeah.
But I know that if I take too many of those, I'll get even more overweight. So, there's certain dietary recommendations, right? And really, I think we need to try to improve the diet of South Asians, focus more on whole grains, legumes, beans, fruits, vegetables. It's tough to find vegetables, that are not cooked in korma or masala.
Does it the composition changes if you cook with the vegetable
No, but
fat?
well, the main problem is you're just adding a lot of calories, right? So let's try to get more steamed vegetables and olive oil. That would be better, right? And then and focus on olive and canola oil, and try to avoid ghee and palm and coconut products and fried foods, right? One thing that not everybody, most physicians have heard of the American Medical Association, but most have not heard of the Academy of Nutrition and Dietetics. And they have many dietitians of Indian and South Asian ancestry, and they have a special group called the Indians in Nutrition and Dietetics that focuses on trying to improve the diet among South Asians. And some of my colleagues are dietitians and here in California and involved in that group. And so
I'd love to interview one of them, definitely.
Yeah, and certainly I can recommend one to give a lecture for you sometime on how to improve the Indian diet and how there's an Indian Mediterranean diet, right? The Indo-Mediterranean diet you should think about, okay? So I just put these slides just to make sure that people are aware of the newer Life's Essential 8 metrics, right, from the American Heart Association, right? So this really focuses on the diet, physical activity, nicotine exposure, and now sleep health was the 8th thing that was recently added. 7 to 9 hours of sleep a night is optimal, right? Less than that or more than that is related to higher risk. And then recommended levels for body mass index, lipids, blood pressure, and glucose. So this is
how important is body mass index, doctor? I interviewed another mathematician. She came up with a new measurement. It's called a body round index. It is a calculus. They put that in. Dr. Eric
body
Topol
roundness index. Yeah, I mean, it's not typically used, and body mass index is of course not the best measure, right? So we were just talking about waist circumference, and I think as far as we need to get physicians to measure waist circumference better more often, because BMI is not very accurate. But these are, of course, just basic measures for the public to be aware of. And there are apps that are completely free to use to do the My Life Check assessment, right? So if you know your values for these different things, you know your total and HDL cholesterol, you know your glucose, you know your blood pressure, then you can get a score. You can get a score and you can get a report. And I highly recommend this to be promoted to the public, right? So, so the physicians on this call, you can tell your patients about this, because we know that if you're at ideal levels of most of these factors, like if you're at ideal levels of 6 of these factors, right? Non-smoking, ideal BMI, physical activity, healthy diet, cholesterol, blood pressure, and glucose. Your risk can be as much as 89% lower. Okay, so these are not data specifically from South Asians. This is from the ERIC study that was included African American and white individuals. But the concept here that I want to get across to everyone is the importance of multiple risk factors and their control, and how much that can lower your risk compared to if none of these factors are in control. So let's talk a little bit about why do we have, so now we're going to kind of switch gears and focus on lipids, right? So why do we have more aggressive lipid management recommendations that I'm going to talk about? So we talked about the epidemic of increase in cardiovascular mortality in Indians and South Asians. They develop heart disease 10 years earlier than other ethnic groups. Coronary disease tends to be more severe because they have smaller coronary arteries, and this can result in premature coronary disease. And LDL levels might actually be a little lower than Americans and Europeans, but still, despite that, they're getting coronary disease earlier. We talked about the atherogenic dyslipidemia, right? High triglycerides and low HDL. And remember, in our ACC guidelines, South Asian ancestry was specified as a risk enhancing factor. And we're going to talk a little bit about the LDL targets that the Lipid Association of India recommends, that are the lowest targets in the world, because we feel that the targets, the other international targets, are not appropriate for South Asians because of their premature disease. So, so there are different, what we call major risk factors: advanced age, smoking, high blood pressure, low HDL, and then high risk features, right? So family history, metabolic syndrome, coronary calcium. I've been involved in that for 35 years. So I'd be happy to talk to you about coronary calcium sometime, metabolic syndrome. And we're going to focus on lipoprotein little a, 50 or higher. At 20 to 49, it's a risk modifier. High HSCRP, triglycerides, female specific factors, right? Any physician who sees female patients needs to ask about whether they've had premature menopause, preeclampsia, gestational diabetes, polycystic ovarian syndrome, and other factors that can increase their cardiovascular risk, and then high polygenic risk score.
For Indian woman, is it for specific to Indian woman or in general all women?
This is in general, but these recommendations are from the Lipid Association of India, so they also apply to Indian and other South Asian women. So when our Lipid Association of India divides people into different risk categories, as you can see, right? So our very high risk people, for example, diabetes with target organ damage or multiple risk factors, higher coronary calcium scores, multiple high risk features, or established ASCVD. And then the extreme risk group, right? So the people with recurrent ACS are in the higher category B extreme risk, and category C, if you still get recurrent events, even if your LDL is around 30. So we want to see these LDL targets below, at least below 50 in our very high and extreme risk groups, ideally below 30, particularly if you're in category B. And then, as I said, if you suffer recurrent events despite an LDL of around 30, this can be suggested for more intensive risk factor management and I talked about the other therapies we need to think about: GLP-1 receptor agonists, colchicine. You got to do everything you can, and even an LDL target of around 10 to 15 can be reached in some of these individuals. So let's talk about lipoprotein a. Okay, this is an LDL-like particle where the ApoB is covalently linked to an ApoA by disulfide bonds. The size is determined by the number of these KIV2 repeats, these Danish type structures. And Lp(a) is pro-inflammatory, pro-thrombotic, and pro-atherogenic. It's primarily genetically determined, okay? So what you're seeing is that levels pretty much reach your adulthood levels by the time of adolescence. Levels tend to be higher in women, and particularly in postmenopausal women. So that's where you might want to retest it after a woman has gone through the menopause. Current international recommendations note a normal level is below 50. And in India, we consider 20 to 49 a risk modifier. And then increased levels are 50 or higher milligram per deciliter or 125 nanomoles per liter. Remember, Lp(a) can be measured either way. It's preferable to have a nanomole per liter assay because those are isoform independent, but the most important thing is to get a measure. So if your lab only does it in milligram per deciliter, you should definitely take it. So 1.5 billion people in the world have elevated Lp(a), 65 million people in the US. What's interesting that I just found shocking was 1/5 of the elevated Lp(a) levels in adults happens to be in South Asian individuals.
How do you test LPA levels? What is the testing mechanism, Dr. Wong?
Well, there's actually ELISA assays and there's other types of assays too. But what I was saying is that, that ideally you want to get a nanomolar per liter assay instead of the milligram per deciliter assay, but you can take either. Okay, the most important thing is to get it measured, there's limited standardization, but overall, and there are variations between labs and between assays. But in general, if you have a high level, it's going to be high among most of your assays, or if your level is very, very low, it's kind of where you're in the borderline range that some do recommend, perhaps.
What kind of a genetic testing you do that, Dr.
Wong? Well, there is there are Lp(a) genetic variants, but it's generally not done very often. Okay, we're mainly making treatment decisions not based on whether you have a genetic variant, but more based on your level of lipoprotein(a) as measured. So guidelines do not universally recommend genetic testing, but if you have it available, it could help motivate the patient better, right? So having a positive genetic test, whether it's for FH or for Lp(a), can help motivate the patient. So this slide here really shows that there's a wealth of evidence where elevated LP(a) is associated with higher risk from meta-analyses, Mendelian randomization, genome-wide association studies, and you see higher risk, particularly for MI and aortic valve stenosis. People with aortic valve stenosis really especially need to have their LP(a) tested because that might be a cause of their aortic valve stenosis. We know higher levels do relate to greater progression of aortic valve stenosis. Other events, even heart failure and stroke to some extent, and atrial fibrillation have been linked to elevated LP(a). This was a study we published in JACC last year, pulling 5 major U.S. cohort studies, found a 46% increased risk if you were above the 90th percentile. That averaged about 53 milligram per deciliter. And importantly, we found that it was a stronger risk predictor in people with diabetes. So if you have diabetes and you're in the above the 90th percentile, you have a 92% increased risk. So as I said, 1 in 4 individuals in the world with elevated LP(a) happen to be in South Asia, or I should say 1 in 4 people in South Asia have elevated LP(a), but that's a large number of people, right? 495 million, far more than we see in North America. And you can see that compared to other ethnic groups, except for African Americans and people of African ancestry, South Asian people have higher LP(a) levels. And the UK Biobank nicely showed us, though, that per increment in elevated, so the relative risk was similar, right? So not greater in South Asians, comparing 150 nanomoles to under 150, 1.37, that was between that of black and white people. But look at that incidence per 1,000 person years, right? So the absolute risk increase is quite a bit greater because South Asian people, to begin with, have higher baseline risk, right? So even though the hazard ratio was not much greater, the added absolute risk is greater. So that's a very important point to make. Here in the InterHeart study, an elevated LP(a) was associated with more than a 2-fold greater risk of myocardial infarction. This was greater than we saw from the other ethnic groups, right? So like in Latin Americans, it was 1.67, Chinese 1.62, but South Asian people 2.14. So LP(a) is a stronger risk factor in South Asian than in others, at least from the InterHeart study. And they had the highest population burden, right? So the population attributable risk of MI was, 9% of that was explained by elevated LP(a), more than for the other ethnic groups. So our guidelines really around the world are uniformly aligned on family history, and this is in the U.S. These are U.S. guidelines, but most recently, the NLA has adopted universal screening at least once in all adults. And important to understand that also the European and Canadian guidelines and the Lipid Association of India recommends universal screening. So we go to the LP(a) testing recommendations from the Lipid Association of India. Once in all adults, at least 18 years of age,
Is it widely available, Dr. Wong, this LPA
testing is
testing?
very widely available, and in fact, you would be surprised. I was walking around the little streets of Delhi. You know those like alleyways and New Delhi
Yeah.
with all the cheap restaurants and little stores and with motorcycles crowded. It's amazing. I just randomly walk around and you see laboratories testing LP little a. So I think it's more available in India than gosh, I don't know. I would. I think it's easier to get it off the street in India than here in. You have to go through a process, and you find a lab that will do it here in the U.S. But it is widely available, and most insurances in the U.S. Do seem to cover it. My cardiology colleagues don't seem to have any problem ordering it. It's possible that in certain underserved populations with Medicaid, it may be more difficult to get that reimbursed. But the average price is about $50, right? So if you're talking about, people spend that much for lunch or dinner all the time, but you're talking about the most important genetic risk factor for cardiovascular disease. Okay, so here, and then you can see.
Can you compare the other ones like calcium scoring? Is it comparable to that kind of scoring? You get better
calcium
results?
scoring, remember, is directly measuring subclinical disease, right? And so we really see these as complementary, right? So in somebody with a high calcium score, a high LP little a does seem to add further added risk, right? Whereas in somebody with very low risk due to a zero calcium score, the LP little a seems to be less important. That's what the published studies are showing. So other.
Kavana is teaching me subclinical thing.
But certainly, and we're very aggressive about lipid management in India based on the extent of subclinical disease. So certainly, it's a good idea to get a calcium score to see where you stand and if you have subclinical atherosclerosis, because that would warrant more aggressive lipid management for sure. So other patients with like premature ASCVD, FH, family history of premature disease or recurrent events, patients after an ACS, these all should be considered for an LP little a testing, right? And remember, 20 or higher indicates some modest increase in risk. 50 or higher is definitely high risk status. Testing throughout the world and here in the United States is very, very poor, right? All these studies from well-known institutions show, for the most part, less than 1% are being tested. And so it's a big, big problem. We need to promote LP little a testing. We have a best practice advisory. We implemented it UC Irvine. So patients who have a history of ASCVD, personal or family history, aortic stenosis or FH or elevated LDL 190 or higher, the physician gets sent a message to consider LP little a testing. So we have some evidence that testing rates have increased because of that. So one thing that we have to understand, so, as I said, regardless of the test you have, if you have a very low level, you're probably likely to be low. very high level, you're likely to be high. But it's a gray area, right? Like 30 to 50, where, maybe one assay might, overestimate or underestimate compared to another. And you might consider retesting. But for the most part, many people will be low and some will be extremely high. It doesn't matter so much. So one of the concepts that we have to understand, because a lot of physicians will say, well, we don't have any approved pharmacotherapies, right? We only have LDL apheresis. It's not widely available, and there's drugs in development. Not part of this talk, but I'll leave a few minutes, hopefully, for discussion. I'm almost finished here, but the point here is that you identify a patient with an elevated level, right? The higher the level is, like in the dark blue bars, this person has a lifetime risk of 43% if they have many risk factors. But if you just reduce those risk factors, reduce the risk factor burden, you can reduce that excess risk from 43% down to 9%, right? In someone with a high Lp(a). If they have a low Lp(a), that excess risk is 25%. If you have a lot of risk factors, and you're reducing it down to 5%. So the point is, you find someone with elevated Lp(a), it is actionable, and you want to lower their overall risk. So improve their lipid management, their diabetes or hypertension, get them to stop smoking, follow a healthier diet. So all these things, right, as shown on the bottom here. So it's a risk-based prevention approach. In the high risk people, as I said, consider these other therapies, aspirin, even GLP-1 receptor agonists, colchicine. And then the one other thing is we can include Lp(a) in a risk score. So here you can multiply it by your 10-year predicted risk by 1.11 raised to the power of the Lp(a) in nanomoles divided by 50. This was published by the AHA 2022 statement. But we created our own Lp(a) risk score recently based on a US cohort. What I just showed you here, that 1.11 comes from the UK Biobank. But we're published our risk score a few months ago in Circulation, Genomic, and Precision Medicine. And the way it works is you have these factors, and right now we don't yet have an app, but we're hoping we can develop an app for this. But the idea is that in a patient without Lp(a), with the risk factor profile shown there, their risk would be 17.9%. But you add in that Lp(a) elevated in this black male at 80 milligram per deciliter, your risk increases to 24.2%. So you can see how a risk score like this can promote clinical actions. You would definitely want to put that person on a statin if they're at 24%, but if they're at 18%, maybe you're kind of on the borderline and the patient may be reluctant. So you want to think about that. Why test Lp(a)? It can help identify people's risk and promote intensive risk factor management through shared decision making. Ultimately, it may help in healthcare savings by preventing events. And then the last slide here, this kind of summarizes, right, our prevention strategies for South Asian patients, taking care of assessing both modifiable and non-modifiable risk factors and trying to address those modifiable risk factors that we talked about earlier. And that's all relevant. In a person with elevated Lp(a), reduce all these modifiable risk factors as shown on the bottom there: diet, lifestyle, physical activity, dyslipidemia, hypertension, diabetes, and really, culturally tailored strategies for our South Asian patients, right? Not all our U.S. recommendations are and are necessarily culturally tailored for South Asian and other ethnic groups. So we need to consider that. So with that, thank you very much for your attention. I guess we just have a couple minutes for any.
Yeah, you can a little bit extend a wonderful lecture. It's really, really very informative source. You know that you're saying LPA testing should be gold standard. Before I hand over to Kavana, I'm much more better knowledgeable than me. So is the LPA testing? It should be widely available and it should be done across the board. That's what you're recommending, right? If I understand you correctly.
Yes, exactly. Yeah, any adult who has not had their LP(a) tested, particularly since it's more prevalent in South Asian individuals, and South Asian individuals have a higher baseline risk to begin with. It makes it even more imperative that this be tested among all South Asian adults. Certainly, ideally first you're going to want to make sure the higher risk ones, right? Those with ASCVD, those with diabetes, those with multiple risk factors get tested first. Yeah.
Dr. Kavana she practiced in India. Now she is in Silicon Valley.
Okay.
She sees both Indian patients in India, Indian patients here. So tell us a little bit about your experience. You get your questions, Kavana. Go ahead.
Okay, well, thank you for that introduction. I'm really excited to be joining in this part of the conversation with Dr. Wong. Now, we've heard about your tremendous impact in preventative cardiology, and I'd just like to spend the next few minutes exploring your perspective on innovations in this area. So you've spoken before about the concept of residual risk and that layer of danger that still remains even after we still check all the boxes, like what you mentioned: hypertension, LDL levels, and waist circumference, and so on. Now, despite advances, residual risk still remains a major challenge in cardiometabolic diseases. So, where are we still missing the mark, and what new strategies do you see emerging to kind of close that gap?
Yeah. So I think still, our even this treatment of traditional risk factors like lipids is highly inadequate, right? We know even among all our patients throughout the University of California system with ASCVD, about over half are not on a high intensity statin, and only about half of those who are adequately controlled. So lipid management needs to be improved. Blood pressure, we're doing better, but that can still be improved. Diabetes, we can also improve. But I think one of the things where we're missing the mark is we now have newer evidence-based therapies with cardiovascular benefits that are still not widely used, right? Particularly the GLP-1 receptor agonists, SGLT2s. Of course, heart failure people have embraced them because of their heart failure risk, but we're not maybe thinking of all these, particularly the GLP-1s, as cardiovascular risk reducing drugs, right? We're stuck on thinking of them as diabetes and perhaps obesity therapies. But our patients need to understand, right, that it's not just about, they're not just about losing weight. They're about reducing cardiovascular risk factors. And we've projected that if if all adults are, if eligible adults with overweight or obesity are put on, say, for example, tirzepatide or semaglutide, right? 93 million U.S. adults would qualify, and we could prevent 1.5 to 2 million cardiovascular events over 10 years. So the benefits are staggering, and we're not using these therapies as often in our higher risk patients as we should. Also, low dose colchicine, right, shown by several clinical trials to have dramatic benefit, and it's an inexpensive therapy, right, under $100 a month, many times under $50 a month. So and that's in the guidelines, acute coronary syndrome and chronic coronary disease guidelines.
It may be irrelevant question here that I have. What do you think of intermittent fasting reduces the prevention? Anything related to the preventive side of the episodes, the intermittent fasting?
Yes, so I can recommend a great speaker for intermittent fasting later. But there is emergent evidence that it can definitely help in terms of improving cardiometabolic risk factors. And my colleagues, both Dr. Taub and Dr. Wilkinson, have done some great work on that.
Okay.
Yeah, wonderful.
So
It is totally an honor to talk with you, Dr. Wong. You really gave us so much information. It's a really golden, it's a really our benefit to the physicians, health, people like Kavana can get benefit from all the studies you have done.
Definitely.
You're truly an asset and a treasure for the American cardiology field. Thank you so much for joining with us, Dr. Wong.
No, it's certainly a great pleasure to meet with you all today, and really enjoyed the opportunity. And you all take care. Thank you so much.
Thank you all. Good night.
We are retailing their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it